First, let me welcome Dr. Srinivas Reddy. He is going to talk on early allograft dysfunction after LDLT, followed by a case presentation by Satish. So, Dr. Srinivas Reddy is Director of Liver Transplant and HPV Surgery for two hospitals from Chennai and Hyderabad. He is overall heading the two units, and he has enormous experience. He has trained in prestigious Chandigarh PGI MS. After that, he went to UK, where he did specialty training in Leeds Royal Infirmary. He had his liver transplant training. After that, he came back to Global Hospital. He was under with Professor Raila's team. Now he's heading here as a director of liver transplant unit. He has enormous experience in ABOI liver transplantation and also pediatric liver transplantation. He has great ability to do all the complex HPV surgeries also. Dr. Srinivas, please start your talk.
Thank you, Dr. Rajnikant. Thank you for the kind introduction. I joined Rajni and Dr. Selva in welcoming everybody for this webinar series. This is the first, I hope, of many, and we are very fortunate to have Professor Nigel Heaton and Dr. Wael Jessam and other members of the King's College Liver team to be involved with this, because that definitely raises the standard of the whole discussion. And so I'm going to start off with early allograft dysfunction in the LDLT setting, followed by, I think, Professor Nigel Heaton will do the talk afterwards, after I finish. Okay, can I share my screen?
Yes, please.
Okay, can you see my slides?
Yes, sir.
Okay, thank you. Okay, so I'm going to talk about early allograft dysfunction in the living donor liver transplantation setting. It is a challenging issue, and most of the speakers of my colleagues across the country will know that it is not something that is fairly straightforward to deal with, and needs a lot of and involves a lot of challenges. To start, what exactly is early allograft dysfunction? It is basically an insufficient function of the liver graft in the early post-transplant period, with an associated increase in post-transplant morbidity and mortality. And the causes for this can be many. It's usually multifactorial. It could be the recipient condition, it could be the quality of the graft, it could be the volume of the graft, and with technical issues, quality of outflow, biliary reconstruction, or it could be sepsis, which might be sepsis. So to look at the pathophysiology of early allograft dysfunction in a bit more detail, I think the basic problem here is an imbalance between the metabolic need of the patient, the recipient who is having the transplant, and the quality of liver function that the new graft can provide. And if you look at it in a bit more detail, if this graph shows the transplant timeline, so you can see where the transplant is done, and then the x-axis is in terms of metabolic units, whether it's metabolic requirement of the recipient, or it is the amount of metabolic function that the liver graft can provide. Now, if you take the example of a fairly straightforward transplant, you have a patient with a MELD of 15. Patient has a basic metabolic requirement, which goes up immediately after surgery because of the stress of the operation itself, but it rapidly comes down and normalizes as the patient recovers. Now, if you transplant a good quality liver for this patient, let's say a graft with a donor of age 25 years, the graft has good initial function and rapidly recovers from the ischemia reperfusion hit, and the patient does well, patient goes home. On the other hand, if you take a sick patient, let's say a MELD of 30, this patient already has a high basal metabolic rate, metabolic need, demand, because of the decompensated status, maybe recent sepsis, hospital admissions, and they're going to have a much higher increase in metabolic demand after transplantation, because they do not really tolerate major surgery well. So these patients will have a higher peak they will take longer to recover, and they'll take a longer time to come back to the basal state. Now, a good quality graft will still manage. There might be an initial deficit in the early phase of the or period of the transplant where the function is still less than the need, but with supportive care, it should improve and the patient does well. Now, if you take a borderline graft, let's say a donor liver of age 50 years of age, now these grafts, we know they don't do as well. Their initial basal function is not excellent, and then they also take a longer time to recover after the transplant hit because of the ischemia perfusion injury. So there will again be a period of deficit, and this is much more in a patient who's a sick patient because of the gap in terms of the metabolic function of the graft and the metabolic demand of the patient. Now, if this patient has a hit in the post-transplant period, it could be an episode of sepsis, it could be an episode of rejection, a small bleed, or whatever, the demand increases further. And then if you have a failing graft and you have a sick patient and has another perioperative hit, the patient will not do well. The patient will have problems. So this in basically is how early allograft dysfunction is my understanding of early allograft dysfunction. So obviously much more simple than what it actually is, but I think this is in the synopsis of it. Now, what is special in the LDLT setting is the fact that you have an additional component here, a partial graft, which provides two additional components to the game. So one is the hyperperfusion injury in a partial graft and the problem with graft regeneration. I think portal hyperperfusion in small grafts has been studied quite extensively in the last 10 to 15 years. Effectively, what happens is cirrhotics have a much larger portal flow as compared to a normal healthy person, and this is because of the hyperdynamic circulation. And when a partial graft is implanted into a patient like this, the entire portal flow then goes through a very small sinusoidal bed. This leads to sinusoidal hypertension. There is shear injury of the sinusoidal endothelial cells, releasing lots of cytokines and leading to an inflammatory response. So this is one part of portal hyperperfusion. The second part, which is probably related to this, is related to arterial ischemia. We know that the portal flow and arterial flow in the liver are reciprocally controlled. So if your portal flow is high, the arterial flow comes down, reduces. And this actually has a very deleterious effect in the partial graft. Now, because of the high portal flow, arterial flow reduces. And the main things that get hit because of this are first the biliary epithelium, because they are primarily supplied by the arteries. And secondly are the centrivenular areas, the perivenular areas of the hepatic lobule, because they are the farthest from the portal structures. So with the combination of low arterial blood flow and sinusoidal injury, the delivery of nutrients and oxygen to the perivenular hepatocytes comes down significantly, leading to graft injury. So these two combine to cause significant graft injury, and you would see that most of these patients actually do well for the first day or two and then start gradually deteriorating, which is slightly different to the DDLT setting where from day one the patients struggle. That's because all these, the sinusoidal injury, the effect on the graft, the biliary, the cholangiocytes, it all takes a couple of days to actually manifest clinically. Now, the icing on the cake, or to make matters worse, is the problem with graft regeneration. And when I say the problem with graft regeneration, it's actually not less regeneration, but it's actually more regeneration in the graft. So there's been a lot of studies which looked at the amount of graft regeneration which happens in partial grafts in patients who have early allograft dysfunction. This is one such study, and it shows that the graft volume actually increases faster in patients who have early allograft dysfunction as compared to patients who do not have early allograft dysfunction. And this is expected because the patient is having a deficit of hepatic function. So there is a greater pressure on the partial graft to regenerate quickly. The problem is not in the quantity of regeneration, but actually in the quality of regeneration. Now, this graph tells us about the rate of regeneration of various cellular components of the liver. Now, the liver has multiple cellular compartments. There is a hepatocyte compartment, there is a biliary ductular compartment, and the sinusoidal endothelial cell compartment. When you implant a partial graft, the first thing that starts regenerating is the hepatocytes. Now, hepatocytes start dividing very quickly within 12 hours of implantation, and usually reach their final mass, which might be twice the original mass of hepatocytes within 40 to 72 hours. Which is a good thing. The problem is this is not matched by a regeneration of the remaining cell compartment. So these hepatocytes form what are called as islands of dysmorphic cells without adequate blood supply and without adequate biliary biliary ductule. So we have these clumps of newly formed hepatocytes, which are to an extent ischemic because there's no sinusoidal endothelium to supply them with nutrients and oxygen, and they become cholestatic because the bile that is being produced by these hepatocytes cannot be secreted into the bile ductules, and this leads to a lot of disturbance of the architecture and liver dysfunction. Now, in fact, studies have shown that medications and drugs which actually slow down liver regeneration by blocking certain growth pathways actually improve liver function, because the slow regeneration becomes much more coordinated between the hepatocytes and the SCCs and the non-hepatocytic cell compartment, leading to much better liver function. So this is the other problem with small size grafts or partial grafts. The problem is of over but dysmorphic regeneration.